Hello, everyone. Welcome to this webinar, the third in the series of the new Supervisor series, Planning Learning with Your Registrars. Can I start with an acknowledgement of country? We acknowledge the traditional owners of the land in which this meeting is taking place and pay respects to elders past, present and their families. And you may know me, Simon Morgan. I'm a medical educator working here in Newcastle on the land of the Wabakal people, and very sincerely pay my respects to the traditional owners of the country I'm joining you from. And it's a great pleasure to introduce my co-facilitator tonight, Dr. Ed Pollines, who looks like he'd either rather be or is at the snow. Ed is a very dear friend of mine and a very experienced and capable both GP supervisor and medical educator coming from Geelong. He has done a whole bunch of stuff over his career, including working in remote Aboriginal communities, doing overseas aid work in places like Vietnam and Sri Lanka. In East Timor, he has been the sub-dean of the Rural Clinical School in Wangaratta and currently working in two very interesting locations at Wathaurong Aboriginal Medical Service in Geelong, and also in the Living Room, which is a medical service clinic for homeless people in central urban Melbourne. So Ed, wonderful to have you along.
Yep. I don't know where you get this stuff, Simon. That's enough of an introduction. I'm a supervisor like all the other supervisors here.
That's probably the main thing to say. GPSA was very excited to be able to launch this new supervisor series. So some of you may be on because you know this is part of that. Others may have just stumbled across the invitation and thought planning learning is an important topic in its own right. But this is the third in a series of 8 webinars, I guess in a sense loosely connected, but certainly we see as core learning for new GP supervisors. You can see the upcoming webinars, and we're very we'll warmly welcome you to those in the future. But this webinar tonight is on planning learning. And actually, I'll just go back to that slide because you can see some pretty core things that, you know, when you think about the role of the supervisor, we think of teaching. We think of sitting in with our registrars and analysing consultations and giving feedback. Informal and formal teaching, you know, the themes of clinical reasoning and professionalism. And as important as it is, I think the whole notion of identifying a registrar's learning needs, planning learning, and explicitly making that connection about them as a learner in the practice sometimes is overlooked in terms of its importance. I mean, it kind of happens sometimes in the background, but it may be just a bit organic. And I guess Ed, as I say, an experienced supervisor and ME, would that be your observation?
Absolutely, Tom.
And so Ed was very chuffed about being asked along, and I think because it's an area that I think as educators we do see sometimes, I don't know about neglected, but just doesn't have the prominence of teaching and feedback and the rest of those skills. Now, a bit unashamedly, I'm going to just revisit very quickly some of the content that we talked about in webinar 1, which was around the roles of the supervisor. And this Venn diagram may be familiar to you. When we think about supervision, I guess arbitrarily, and certainly one model would suggest, there's 2 key aspects to that. The clinical element is the patient safe. The educational element is the learner learning. So educational supervision, which I guess in a sense we've got a stronger focus on tonight, is around educational development, and planning learning sits really firmly, identifying needs, providing teaching on the basis of what you've identified in terms of needs, and providing feedback on performance. But with clinical supervision, which is very much around patient safety and quality of care and making sure the registrar is practicing soundly, planning learning sits as integrally. Learning needs around patient safety, formal and informal teaching, you know, calling for help, the whole nature of how we teach around quality practice, and of course providing feedback. So I don't see that planning learning fits in educational supervision. I think it sits at the intersection of these 2 aspects of supervision, right squarely in the middle. And so if there's one message I'd ask you to take away from the webinar tonight, it is the importance of this aspect of your role, not something that maybe just happens in the background. It's the registrar's responsibility to learn and identify, work out what they need to learn, but how critical that is, both to their development, but also the safety of their patients and your patients, of course. So I don't like talking about too much theory. And in fact, the reason that we have you able to speak and have your videos on tonight is that we are going to break you up into a couple of groups and just have a bit of a yarn and share experiences. But a little bit of background as I'm going through, just to, I guess, set that up. This is the Johari window, something I'm sure you've seen before, and something that has the moniker Rumsfeldisms, because Donald Rumsfeld, who I think very recently passed away, talked about the known knowns and the known unknowns and the unknown unknowns. And I would really hope this is a model that you guys use as supervisors when you think about your registrar's needs. And so just to put this into some sort of context, Ed is a clinician. He works in Aboriginal health. He's a GP. He's a lifelong learner. And Ed, tell me, what are you
Put me on the spot, Simon.
So what's known to you, and I guess known to me, in terms of your learning needs and your knowledge areas?
I think at the moment, what is really known to me is long-acting injectable bupe, because I've started doing it 18 months ago, and now I'm doing a lot of teaching other GPs and some registrars in the area. So I know the protocols. Whether I can fit it on the actual individual patients that turn up is different, but I actually know that I know the protocols and I can tell anyone about it.
And that would slide, I think, fairly squarely into the unknown unknowns for me. I don't think I had any idea that I didn't know anything about that. So there you go. And this is the whole nature of what we're doing, that suddenly the registrar says, I didn't even know to think about that. And now I realize, you might say, well, I did know a little bit about that, but in fact, I had no clue. So perhaps, Ed, what is known to you, but not known to others? What do you hide your knowledge about? And this is an important aspect of registrars coming and they know that they're not very good at stuff. They don't particularly want to share it at times. So is there anything, Ed, that you know that you're not, your knowledge isn't so good in?
Yeah, I must admit, I work in Aboriginal health a lot of the time. Renal medicine. I blame it on Melbourne University in the second half of the last century, that obviously some people find kidneys really simple. I don't. And I go to things every 2 years because I just don't know. And they bring me up to a level of understanding, and then that dribbles out usually as I'm driving home. And then 2 years later, I go to another thing to say, what in the world's going on with the treatment of people whose EGFR is low?
So now if I was Ed's supervisor, I would probably know, and he was my registrar, I would know some things. I would be aware of some of his skills and knowledge that he isn't really familiar with. And so they're the things that are not known to him, but known to me. And it might be, Ed, you know what? My observation is that when I've sat in with you, you do struggle sometimes to give a good explanation. Really? I wasn't aware of that. Well, that's just something I picked up. It's something to be aware of. So that's something that we can fill that gap. And clearly, through a whole range of things, the sorts of things we'll be talking about later in the series, sitting in with registrars, random case analysis, all those formative assessment aspects of teaching, we can pick up the unknown unknowns. And this is the Johari window, named after Joe and Harry, believe it or not. So this is the new Ed Sim iceberg. Apologies to Joe Harry. And I kind of like the notion of an iceberg, because under the surface are all these unknown unknowns. The things we can see are maybe the knowns. And it's our job to, invert the iceberg or dive below the surface and help them identify those unknown areas. So we're getting on to our first small group, because I just, at this point, want to make the differentiation between what registrars want to learn and what they need to learn. And this is a really interesting paradox. And I'd ask you all to reflect on the last CPD events you went to. And in fact, this is one. Maybe you're all really good at planning learning, because that's what we do as GPs. We go to stuff we're good at and we like and we know. And we see it all the time, that people turn up to a session on STI management and they work in sexual health and they just want to brush up their knowledge. Maybe they just want to critique the the presentation. But we know the known knowns, we often go and reinforce things. And the known unknowns, we want to learn about stuff we don't know when. And the triggers are, we see a patient and we don't know what's happening. So that's very much a known unknown. I didn't know what to do. I've got to go and look it up. If it's interesting, that sounds a really interesting area to pursue. I don't know anything about it, but I've identified that it's a learning gap. And certainly when we're sitting in exam. And this falls very squarely into the clinical domain, pretty much. And so, as you can see, when I talked to Ed about his unknown learning needs, it's not clinical often. Maybe frequently is, but often those aspects of practice that are less clinical. And so that's, I guess, a way just to set up this small group. And so what I want you to do, and I think we'll give it about 8 minutes in your groups, is to answer 2 questions. What do our registrars need to learn? Now, clearly they need to learn all that clinical stuff we've talked about. That's a given. And they've got to pass their exams and they've got to manage their patients safely. But what else do they need to learn? I want you to reflect on you as a GP and the sorts of skills and knowledge and attitudes that you practice every day that, in fact, they may not even be aware of that they need to know and learn. And so what are those common unknown unknowns? So what we're going to do is to break into groups for about 8 minutes. And we'll put you into groups of about 8 or so. And it's self-directed, self-facilitated, self-starting. Introduce yourselves, let people know where you're coming from, and then share your experiences and see if you can answer those questions. And we'll come back to you in 8 minutes. All right, welcome back. Can I please ask if anything came up in that you really thought my colleague from Broome made this really insightful comment around, registrar learning needs and what is a really important aspect of our role in terms of identifying them, please put it into chat. Or even more bravely, if you would like to volunteer something that you said or that you heard a fellow supervisor say that you'd like to share with the group, you have the capacity to speak. So please, 1 or 2 comments would be great.
Elizabeth's added the art of interacting with the patient.
Fantastic.
Chat. I think that's a...
And, isn't that wonderful, Ed, the word art? Because how else does an artist teach their apprentice without observation, it's not book learning, it's not guidelines, it's the art. And that's possibly the nub of what we're getting at here. So if we just talk about some of these aspects.
Yep. I love to in the chat. Simon, can I interrupt you?
Oh, I can. I can't see the chat because it's kind of hidden away, but please.
Tristy's brought up the art of time continuing on the art of time management, which is also an art, which especially for, registrars or trainees new to general practice, that art of time management, especially with developing a relationship where you can bring something over time, over weeks, you can take that problem list and say some things we're doing today and something that's a real art to teach a registrar to say, I would like to develop a relationship with the patient. I think that's, an amazing thing.
So I possibly could be accused of being RACGP centric because this is from the RACGP as opposed to ACRM. Apologies to those ACRM supervisors, but really the guts of these areas are the same. And it's about, as we've just heard, the art of consultation, connecting with patients. It's just essentially it's beyond the clinical. It's beyond domain 2. It's communication and population health and professionalism and organizational stuff and just all the stuff that genuinely they may not think about. I mean, they kind of know it's got to be done, but it's our role as supervisors to flag those as learning needs. And so again, I picked these up from the first webinar unashamedly because they are absolutely learning needs and often those that are not well known, not well identified by a registrar. We're doing, the asterisk says that there's a webinar based on it. And in fact, we've done the webinar very recently on clinical reasoning. If you didn't attend that, it was good fun and very, very informative. It's as all the resources are on that GPSA web page. Communication skills, how to interact with the patient, but more importantly, and you can see these things, yeah, of course, that's what I do as a GP, but patient-centered care, is that something a registrar is likely to think about as part of what will make them a good practitioner without us helping identify that as a learning need? Some of those aspects around professionalism, and we're doing a webinar on that in November. Organisational skills, so how actually to engage with the systems. Consultation skills, clearly, and we're devoting a webinar to that, and the whole, the consultation as this vehicle by which we practice. Again, I think so many registrars kind of think it just happens. It's just ED with lower acuity patients. It's not. Managing uncertainty, we're talking about reflective practice, how you actually genuinely reflect on your practice and learn from it. And this is my last slide before I hand over to Ed, and it's a bit of a sort of a model that I put together. Again, I presented it a month or two ago, but I'd like to just to flag it perhaps when we're thinking about learning needs, we're thinking about learning planning, and to think about the registrar, or indeed yourself. In the centre of that circle is the GP. And who does that GP or that registrar, the learner, interact with? They interact with 4 places or 4 aspects. They interact with the patient, they interact with the patient's problem, they interact with the system that's around them, and they interact with themselves. And really, apart from the clinical, where that stethoscope is, which is where they think that's my learning, they neglect potentially, and we can allow them to neglect potentially, all these other incredibly important aspects: patient-centered care, communication, engagement with the patient, organisational skills, and in professionalism and engagement with the system, managing uncertainty, running a good consultation, engaging with the problem, and self-reflection. How do you genuinely reflect on how well you're doing? Reflection on their self. So I think that's a schema really to think about planning learning. And I'll hand over to you, Ed.
I'm not going to dumb it down. I know you can all read slides about adult learning theory. I would like to say that my tip around this slide is that, sitting down with your registrar and acknowledging to them that they are a great big brain on a stick is really important. They got into medical school in whichever country they did medical school in. They got out the other end. They did some hospital medicine, and they made the incredibly wise choice of getting out of hospital medicine and doing general practice. They are an incredibly intelligent person. And yeah, letting them know there's a supervisor, that you'll be their guide. You'll be helping them move around that circle and find some, part of our job is to help them find those unknown unknowns. Because as the bottom bullet point from Simon says, learning is their responsibility. Our job is a little bit like leading the horse to water. From a definition of learning plan, I think it can be a little bit different for every registrar or learner you have in your practice. But I think as the Venn diagram of the 2 circles that Simon showed initially says, learning planning really brings you between that clinical and educational structures that the registrar or the learner needs to focus on. And our job is to do it. I want to bring it back to a little bit of my experience as a parent. And I was telling Simon this a bit earlier, that as a parent, I've always fallen the track, especially with little kids. You go out in the morning, you do something, and then you have something to eat at a cafe or wherever. And then you go home and the kids are like, where's my morning tea? It's like, we had it. We had that cookie and whatever at the cafe. And that's what I've learned. You've got a signpost, for little kids. It's like when you go to the cafe and you have a baby tuna or whatever, you say, this is morning tea. Same for registrars, highlighting the fact that planning their learning is an incredibly important part of the teaching you give them and the time that you give them as a supervisor, and giving it a real name and saying, we need to sit down and I need to help you plan your learning is an incredibly important part of it. And saying, this is the real teaching that I'm doing. I think that's, something that, I've discovered in the sort of the last 5 years has really worked, as saying we need to set some time aside, you and I, and you need to do this too. So modeling that this is an important part of our teaching and an important part of your activities to make yourself not only able to sit exams and become an independent practitioner, but hopefully throughout your career. We're going to break into another small group, and I'd love some feedback at the end of it on those two issues of how can we help our registrars identify their learning needs. And if you guys can share what tools and resources you use and maybe then feed them back to us at the end, that would be great.
All right, so breakout rooms, we'll see you in about 8 minutes. Thank you.
So from that activity, who did want to share some pearls that came out? Especially if you learned something from somebody else in your group.
I learned something which I thought was very interesting. So our group advised that it would be wise to have a checklist of things to do when you first meet up with your registrar. And one supervisor suggested an index, use the index of Murtaugh and highlight areas in green and red and yellow, depending on how comfortable the registrar feels with them. We also talked about using the college strengths and weakness matrix. Another supervisor discussed the discomfort log, and I particularly liked that one. Someone pointed out that they'd use observation. So those were the things that we discussed in our group. Thank you.
Great. Thank you, Taras. And I see that other groups had discussed, index of Murtaugh. And I think we'll head on, Simon, then, and talk about some of the things that I use, that the other people use, that we find helpful at times. I know that lots of supervisors do a fair bit in assessing their registrars' learning styles and making sure they adapt themselves and their teaching processes to each and every registrar. And I agree to a degree that that's what we do, but there's also the way of using your strengths, getting to know your registrar, getting to know how they like to process information, and as someone said before, how they like to process you saying there are some gaps in your knowledge. That's really important. And I think there are lots of ways of just sitting down with your registrar, and I think it's a really important thing at the start of a GPT-1 especially, but if you get a new registrar at GPT-3, or even some of you may get GPT-2s, just sitting down and knowing a little bit about where they're at is really important. And there are lots of different ways of doing that. That we can use confidence grids, we can, definitely, as Taras was mentioning, there are a number of tools that we'll discuss. I think using something like taking an educational history, sitting down with the registrar, finding out, that they may have done a DIPOBS, they may have done a term in dermatology that you've got no idea about. They may have some skills that you can actually bring them up a bit and say, that's going to be really helpful to the practice, and I'll make sure that other people know that you have that skill. Finding out what they're comfortable dealing with is then leading into, what can be some of the things that the registrar is struggling with or is really fearful of at the start of a term.
And can I just make a plug? The IMG guide that's very recently been released through GPSA.
I was going to make that plug, Simon.
Oh, plug. Have you read the guide, Ed?
Yeah, I've used it.
Plug away. Oh, well, there you go. You can talk about.
I'm not sure why it's called the IMG guide. It's really good for international medical graduates, but it's also good for local graduates, I think. And especially in registrars starting in general practice for the first time, it really helps in getting to know the Australian system. Like Medicare is really difficult to understand, I think, not only for international medical graduates and people who have maybe worked in the UK or the NHS, come here and think it'll be similar and then find out it is so different. But a lot of local graduates have no idea as well. We saw a fall down of the PG/PPP system, or having junior doctors get into general practice. Hasn't really happened in the last few years in most states. I know South Australia is continuing on some things, but also finding out if your registrar's done a PG/PPP term or an intense time in general practice through some of the courses in Australia. There might be an immersion year of a a medical student doing a whole year in general practice. Some registrars, it might be their strength. You don't know unless you sit down and take a decent educational history. Sitting down and saying, this is me getting to know you is really, really important for our educational relationship during this, during your time as a registrar here. This is your teaching. The first, the confidence grid was produced by, I think, the Institute of General Practice Education in Western Sydney more than 10 years ago. Is an amazing 41-page grid and you can hand it to your registrar and they can just have a tick sheet. I'm sure it's similar to what you guys do with using the index of MERTAR, but does include quite a bit of specifics. And so they can work through it and look at some of those organization and even ethical areas that they might be saying, yeah, I really, really have difficulty with that. And sitting your registrar down for 45 minutes and getting them to look through that is great. More recently, last year, we saw Jared Ingham and a group from Victoria produce this call for help list, which I think is another great resource of areas that in general registrars have found difficult and where they've needed help. And it's a really good thing to sit down with your registrar and work through those scenarios and say, lots of registrars in the past have and not really felt comfortable with this. What about you? How can we help you improve your comfort in these areas? The other place that we love to get things from, the UK training programs, that puns and dens, the patient's unmet needs and the doctor's educational needs, I think is a lovely nexus. I like to give Richard Eve in the UK a bit of credit for bringing up those, but also moving into a discomfort log of getting your registrar to write down, during the day, those areas that they were uncomfortable with. And often it's, when you get it back, it's often some of those areas you haven't even thought of. They didn't know which unit to refer to at the local hospital for the referral. It was a hand issue. Was it plastics? Was it somebody else? I didn't know. And I've sent a referral plastics, but I'm still not sure. And you can read through their discomfort log, and it really does give you a real insight into areas you can help them with. I don't think anything is better than sitting in with your registrar occasionally and making sure even if they're your regular patients, that you shut up and just watch the consultation and let the patient know. Or almost as good as that is those things that it's always a pleasure to present with Simon, random case analysis, where you sit down and just pick a patient from the last week the registrar has seen and go through it and try and understand their clinical reasoning and try and look at, and you can give them compliments on things they've done, and you can also look at some of their unknown unknowns or the known unknowns that they're not acknowledging to you. Same with, reviewing their inbox, looking at the results and just, looking at why they actually have ordered that many tests or why they've ordered that specific test in that situation can help. As we mentioned in the chat box before, making sure that you are getting a degree of 360 feedback, making sure that you're asking everyone in the practice for their feedback on the registrar, because, in most of our practices, I'm sure the receptionists are absolutely bang on the feedback they get from patients as they leave. And they, if they say, I'm not seeing them again, or that was great, that's always good feedback to give. I think for most of us who are working with registrars who are part of a regional training organisation, there are definitely assessments that registrars do, either especially pre GPT-1 or during their training, and having access to those and sitting down with them and talking about it is really important. And I think all the RTOs have good systems with sharing those, but actually setting aside the time to use them and then bringing the registrar around to say, if there's a deficit, this is part of what we need to put into your learning plan. You know, if you are scoring lowly on all of women's health and still we're not looking at, you know, innovative ways in the practice to make sure you are seeing more women's health, being involved in more women's health, we need to look at ways where you can sit in with someone else. We need to look at ways that we can improve your training to bring in, more opportunities for you to learn and for you to gain experience. I think too, for those registrars who sit exams, whether they are through either college or whether they're external, whether they're doing things online, or as Simon and I were discussing, if they're using, an external provider, GP Academy or any of the others, getting the registrars to bring in when they're struggling or when they've had some sort of assessment is really important. I think a multi-source feedback, it's so important to sit down and pick it apart with the registrar and not to just do it in a half-hour session. Often they're embarrassed if there's feedback they didn't quite like. Touching base on it again in a month or so is really important.
And my take would be, it doesn't necessarily have to be formal. It doesn't necessarily have to involve formal written documentation, but as Ed has, I think, very well stated, to explicitly seek feedback from people around, reception staff, practice nurses, and you'll be hearing patient feedback as you go too, even if that's informal.
I love the concept of planning learning with your registrar. I'm not a big fan of what some of the regional training organisations, other people get registrars to do. That's their business. Our job is to make sure the registrar is planning their learning. If they haven't enforced documentation for a process of learning through their RTO, you can help them with that. That's bureaucratic paperwork. Making sure they are planning their learning is our important task as a supervisor.
You might have some provocateurs, but I can only agree with you, Ed. I think having worked in an environment where learning plans were a requirement as opposed to that much more broad and I think important aspect of planning learning, if it's an exercise book in the top drawer, if it's, as we talked about in the break, a whole bunch of sticky notes, post-it notes, if there's a mechanism to plan learning compared to this often static and frankly bureaucratic artificial thing that gets submitted, then that's you're doing far better. Yeah.
And Stella, I agree. If the registrar resists a formal learning plan, I don't mind. I've talking about Simon in the break or in our reflective bit. Yeah, if there's a whole lot of sticky notes in the drawer and they gather them up every month and put them in a plastic bag and take them home and whatever, once again, we're relying on the fact that they have passed a medical course and have a study plan and are able to process things. They don't need a definite formal learning plan that I like. I just need to know that they are doing it and reflecting on it. And that can be a real process to get down to that with your registrar and finding out the way they want to do it.
So I don't know whether time management was a known or unknown learning need for Dr. Ed Polonez, but perhaps we've identified something along the way. I'm going to very, very quickly summarise that your role as supervisors in planning learning is to essentially identify the strengths and weaknesses, not just the registrar, but yourself, your colleagues, others who can contribute to their learning and teaching, help them identify a learning need, help them meet it clearly. Sometimes it's a bit woolly, but, as Ed's highlighted, I think, really well, to document it some way and encourage them and support them in meeting that is our role. But that most important line is it's not actually ultimately our job to get them across the line or to get them to learn. It's their responsibility. And I think this final slide, for for new supervisors, of which I can see Taras isn't, but some of you may be thinking, oh my goodness, what have I brought in here? I think that's a really important, that the bit you can teach clearly in the scope and the time you have is a tiny part of the iceberg. Some of it's known, known things that they identify, some of it's unknown unknowns, but the vast majority is helping them uncover the unknown unknowns and letting them get on with learning. I do want to, I guess, enthusiastically point you to the now very extensive suite of learning resources, teaching resources on the GPSA website, including the teaching plans, the guides, and webinars just like this one. And very importantly, as Glenn always encourages me to do, to thank the Australian government for supporting GPSA through the AGPT and for allowing us to provide educational events like this one. Thank you very much. Ed, that's always a pleasure. Thank you for passing your some of your wisdom and experience. Thanks so much, everyone, and we'll see you at an upcoming webinar.
Hope to see you all soon.